So I'm going to talk about the GHATI initiative, and I tend to wear multiple hats. So the GHATI initiative was really started with the American College of Cardiology. You know, I'm grateful to be working with the Society of Cardiovascular Angiography and Interventions and the National Heart Center as well, where STEMI really is at the core of what we do. So just as a background, before I tell you about the GHATI project, the WHO reported that 17.9 million people, which is about a third, 31% of all deaths globally, are due to cardiovascular diseases. And of these, 85% are due to heart attacks and strokes, which says that we have a job to do. There's plenty of work for us to do. So the Ministry of Health, represented by the National Heart Center, has taken on these initiatives. So one is starting at the grassroots level. So really looking at atherosclerotic cardiovascular diseases, risk factors, and the National Heart Center has actually launched the risk factor calculator, and hopefully we're gonna learn from that a lot on which directions we need to go. The most recent G20 report actually noticed that the highest mortality rates for ischemic heart disease include Saudi Arabia. So there's work for us to do, again. And the lowest mortality was in countries such as Japan, Korea, France, etc. So when you look at this graph and you look at, this was actually again published from the 2022 report, but is consistent from G20 that was met earlier this year. So what you do see over here is that there is a reduction in overall cardiovascular mortalities. But if we look at the kingdom, again, it's number 2 under Indonesia compared with the other parts of the world. And when you look at it, this is a young population. And that's what we need to remember, that the Saudi population is young. The median age of the Saudi population is 29.4 years. So when you look at age-standardized risks for cardiovascular diseases, that's the blue A panel, and the yellow B panel, you look at it for ischemic heart disease specifically, you look at stroke, etc. Again, you see that Saudi is pretty hot. It's a hot area, which means we have, job security. There's plenty of work for us to do. And again, you look at these statistics over time. Snapshots are not enough. So when you look at the decade, 2 decades, from 2000 to 2020 almost, you look at number 1, which includes Brazil and Saudi and Turkey, etc. You see a plateau over here. You see that the line is plateaued. So we really have not changed our cardiovascular mortalities, as opposed to other countries like India, where it's increasing, and then some other countries such as Australia and so on that again remain, but Argentina, Europe, Germany, etc., there's a slight decrease over the course of the last 2 decades. So again, this is to re-emphasize it. When you're looking at age-adjusted life, years of life lost, again, you see Saudi Arabia where it stands. And when you look at age-standardized years lived with disability, again, you can see the green line over here. It's under Indonesia and China. It comes Saudi Arabia is next, and this is close to 2020. So this is a typical case that we all see, right? Many of us are interventional cardiologists or echocardiographers and so on. This is a patient who came to us in Jeddah with a STEMI, anterior STEMI. You see completely in shock. Impella, here's your occluded LAD. We opened the LAD, ballooned it, stented it, and you start to see that the restoration. But this patient has more than that. This patient also had bifurcation disease, and we ended up stenting and trying to offer this patient complete revascularization. But it doesn't stop with saving the life, right? With just opening the vessel. There's more that we need to consider. Does this patient qualify for an AICD? And if so, when are we going to refer this patient, and where do we refer this patient? What's next is this patient probably has a massive hit to the anterior wall, LV dysfunction. We probably do need to be treating this patient with guideline-directed medical therapy. How are we going to treat this guideline-directed medical therapy? And this is where the GHATI comes in. So the GHATI is a project that looked at the NCDR registries that were conducted in the United States and looking at other countries, so that there's introspection, but at the same time you have benchmarks. So you can see what other countries are doing, what you are doing, and what is happening in the United States. And it goes to what I'm telling you, what's next? So you open the artery, but what's next? So in 2017, that was the question, are the guidelines that are being applied in the United States and Europe applicable to other parts of the world? The Global Heart Attack Treatment Initiative in 2019, leaders met, and the main objective, as you can see over here, is really to improve outcomes, improve guideline and evidence-based management. And what we do know is that a lot of the data that we have is imported. So we need to know, is it applicable to our part of the world? So when you look at it over here, the elements of the GHATI really look at transportation times. Sorry, I think my mic is dying on me. But anyway, it's looking at the basic numbers that we all need to look at. So you're looking at how many cardiac arrests have you done? What is your median arrival to fibrinolytic or to PCI, and so on. But then also other metrics like EF, guideline-directed medical therapy, door-to-reperfusion, P2Y12 inhibitors, and so on. And these are the performance. Now, mind you, yes, there is local guidance and guidelines. So this was actually elaborated by the Saudi Heart Association that looked at those who arrive in a non-PCI facility and those that arrive in PCI facility. And these are just guidance. And again, guidance documents that came out during the pandemic telling us what we can and cannot do. But we need to register how we're doing it. Not just somebody to tell you what to do, but to do it, and then you need to measure what you're doing and see if you're doing it correctly, if there's areas of improvement that need to be done. Again, there's some local registries that have been done, the Space Registry, the Gulf Race Registry, etc., that actually looked at medications use in the first 24 hours, medication use at hospital discharge, and so looking at things like statins and aspirin and clopidogrel and beta blockers and so on. But remember, all these registries that we have are snapshot. They're just giving us snapshot understanding of what happens at that point in time when it was done. It doesn't give you a longitudinal understanding of how we're performing. More than that, it does not really give you an understanding of the novel, MIs that we're seeing now. So we're seeing MINOCA, we're seeing patients with SCAD, and how do these fit into this whole STEMI pathway that we're talking about and their outcomes? Again, when we're looking at very specific populations, so when we're looking at, for example, men and women, and these are both local registries, but again, looking at international benchmarks, and what you do see is that it's very global. That actually when you're comparing men and women, there is, whether you're looking at it by age, the reperfusion, it's much less. Fewer women get reperfused in a timely manner. The mortality hence is higher. And again, what you're seeing is younger women tend to have more high comorbidities, more acutely ill, more hospital mortality, and less use of revascularization and coronary angiography. So this is not a talk on women, but my whole concept is that the GHATI, or looking at how we perform in STEMIs, allows us to see how we're performing. I'm going to keep with the theme of the women, only because when we look at the international benchmarks and we look at all these trials, the OASIS, Gravitas, Leaders, etc., Stop DAPT, that looked at how we, antiplatelets and outcomes with antiplatelets, again, the representation of women was about 25% to 30%. How much was the representation of Arab population, Middle Eastern population, many of whom have diabetes, many of whom have obesity, many of whom have delayed presentation to hospitals? We don't actually know. So that is the whole concept, and that is what we're saying. That's what's next, and that is what the National Heart Center is doing. So again, thank you, and I think maybe time to jump to our cases.
Thank you, Dr. Mirvat. Excellent talk. Just before you leave, Dr. Mirvat, quick question to you. Observing this GHATI initiative, how can we advance this further in a short term and a long term? Because I think it's imperative. We clearly are falling behind. Despite the recent advances, we're still falling behind significantly. And I think the fact that we're doing snapshots and just picking up bits and pieces, it might not be effective. We need to go beyond that. So given your involvement, what's your overview of the situation?
So the overview is that we have to recognize that care is heterogeneous in the kingdom. So there are urban areas, there are rural areas, and even in the urban areas, there are cities like Riyadh that are very well equipped with many centers in proximity, and so door-to-balloon times can be short depending on traffic. There are other areas where it isn't. And so we have to identify these gaps, have to develop transfers to hospitals where they can be transferred immediately. We have to come up with policies for, reperfusion on the way to the PCI-capable centers. We need to talk about shock, and that's the collaboration that we'll be having with Sky over the course of the next year. But really, it is developing policies, improving skill in certain areas, so teaching your transport team what the bare essentials are to safely transport a STEMI patient, a patient with shock, with heart blocks, and so on. So I think it's really allowing the National Heart Center to look into the multiple layers and multiple, there's Ministry of Defense, there's Ministry of Health, there's Ministry of National Guard, etc., so that we're all speaking the same language, we're all doing the same thing, we're all pooling into the same center that allows us to deliver the care uniformly.
Great, thank you so much.